Currently, there are no medical therapies shown prospectively to reduce peripheral revascularization procedures in patients with symptomatic peripheral artery disease. However, we did learn in TRA2 P-TIMI 50 that the PAR1 antagonist Vorapaxar reduced the risk of cardiovascular events in patients with atherosclerosis when added to standard therapy. So to talk about this particular study and in a very interesting new analysis that is in the October 24th issue of JACC Interventions, I am joined by Dr. Marc Bonaca, who is an MD and an MPH, who is an associate physician at Brigham and Women's and an assistant professor at Harvard Medical School, and most importantly for us here, an investigator at the TIMI Study Group, because this is TIMI 50, really.
Yes.
And it is the thrombin receptor antagonist in secondary prevention of anti-thrombotic ischemic events. So remind us, TIMI 50.
Yeah, so TIMI 50 was a large trial with patients with prior myocardial infarction, symptomatic PAD, and history of stroke. And it tested the hypothesis that adding a PAR1 antagonist to standard therapy, aspirin or aspirin and clopidogrel, would reduce MACE, so CV death, MI, or stroke. And overall, it was a positive trial. There was a signal of harm in stroke patients, but for the MI and PAD patients, there was a significant reduction in MACE, and that drug has now been approved for that indication and is available.
So why did you undertake this new analysis?
Yeah, and so we've done a series of analyses, particularly in the peripheral artery disease patients, to look at some of the other outcomes that are really important for this population. Because PAR1 is on platelets, we think about the thrombotic benefits of intensive antiplatelet therapy. And we've previously described an outcome of acute limb ischemia, which is primarily thrombotic, and significant reductions with the addition of a PAR1 antagonist. This new analysis, however, was to describe an unexpected finding. We found that with the addition of a PAR1 antagonist, there was a significant reduction in peripheral revascularization. And this was actually driven by revascularization for claudication, elective procedures. And I think that was a bit counterintuitive for us that an antiplatelet would have that kind of benefit.
So what did you look at specifically and what did you find? Well, give us the data.
Yeah, so we found overall there was a significant reduction in peripheral revascularization procedures. And then we did this exploratory analysis to understand what were the types and what were the reasons for revascularization. Really what we wanted to understand was this all driven by an anti-thrombotic effect, or could there be other effects? And I just want to say again, this was exploratory and hypothesis generating. And we found overall that there were, most of the procedures were endovascular. There were a large number of surgical procedures too, and the majority were elective outpatient procedures driven for claudication. And we found that there was a late separation, there was a robust effect later after long exposure to therapy, and that the benefit of PAR1 antagonism appeared to be consistent across the indications. So whether it was claudication, acute limb ischemia, critical limb ischemia, the benefit appeared to be consistent. There was no interaction, and for the types of intervention.
And you also asked whether efficacy was consistent for patients with or without a history of peripheral revascularizations.
Yeah, I think that was one of the more interesting observations. And one thing we struggle with as clinicians is for whom should we use these medications? Now, these are exploratory data. They need to be confirmed. But one analysis we did was to look at what's the risk of having a revascularization procedure. And we saw a real gradient. If you'd never had one before, you were at lower risk. If you'd had one before, you were at higher risk. And those patients that had an amputation for ischemia were at the highest risk. And interestingly, as you'd expect, that the effect of the drug was greater in patients that were higher risk in terms of absolute risk reduction. So the patients with prior revascularization, or particularly an amputation for ischemia, derived the greatest absolute risk reductions in peripheral revascularization.
So since this is kind of hypothesis generating, what's next?
Yeah, I think that's a great question. You know, we need to understand whether the benefits that you see with PAR1 antagonism are different from antiplatelet mechanisms. And I think that additional studies are needed, both smaller studies to look at mechanism. PAR1's expressed on multiple tissues, multiple cell types, including smooth muscle, endothelial cells. Perhaps there's an effect there. And we need to look with our antithrombotic agents too. I think one thing that's been understudied are the limb effects of the therapies that we use in patients with vascular disease. We have a lot of trials talking about MACE, but we don't understand the effects on the peripheral vasculature with well ascertained and adjudicated outcomes. So I think multiple studies now need to look at this. We've looked at it in other trials as well, and hopefully other studies looking at mechanisms of PAR1 antagonism to understand if there are durable benefits within the vasculature for patients with PAD.
Now, I would be remiss if I did not mention that there are new guidelines for managing patients with lower extremity PAD, and they do, by the way, give a Class 2B recommendation to this agent stating the overall clinical benefits of Vorapaxar added to existing antiplatelet therapy in patients with symptomatic PAD is unknown. What's next in terms of bringing some more certainty to the whole issue?
Yeah, I think that the 2B really for anything added to aspirin or clopidogrel, so for DAPT, for addition of Vorapaxar, and I think the guidelines reflect that we need to do more rigorous study in dedicated PAD trials to understand the risk-benefit. Later at this conference, the Euclid trial will present. That was ticagrelor versus clopidogrel. Some sub-study information will be presented, and then I think we need more trials, dedicated PAD trials. I think we're seeing that PAD patients are different than coronary patients, and they're different than stroke patients, and how they respond to these intensive therapies it's complex. And there's probably a gradient of risk even within the PAD population, and so we need dedicated trials to look at this. And I think the guidelines reflect that level of uncertainty of sort of how we should apply these therapies.
And it's even different above the knee and below the knee.
Absolutely.
Let's just make it more complex, shall we?
Where the disease is and the comorbidities. Do they have concomitant coronary disease? I think we know that's a very high-risk group that tends to benefit from intensive strategies. Without coronary disease, maybe not so much. And then concomitant diabetes is something that has very complex interactions. So I think we need more data, but I think these are promising to show that there are mechanisms that can modify these outcomes.
So to read this paper on Vorapaxar and peripheral revascularization, please see the October 24th, 2016 issue of JACC Interventions. For CardioSource World News and CardioSource World News Interventions, I'm Executive Editor Rick McGuire.